Fantastic. Okay, well, I might get started with our last session in our Spotlight series on implementation science. For anyone who doesn't know me, I'm Wendy Keach. I'm the CEO of Health Translation SA. And Health Translation SA is a partnership organisation which is really trying to build expertise in implementation science. So firstly, before we get into our two presenters today, I'd like to acknowledge the Kaurna people as the traditional custodians of the Adelaide region and recognise Kaurna people's cultural, spiritual, physical and emotional connection with their land. I'd also like to honour and pay respect to the Kaurna elders, both past and present, and all generations of Kaurna people now and into the future. And acknowledge that probably most people on this call are on Kaurna land, but if you're not, I'd like to acknowledge that you may too be on traditional land. You will be on traditional land, and to pay respect to those elders that are in that area. So with that, I'd like to move on to a couple of introductory comments about our Health Translation Spotlight series. This is a new innovation of Health Translation SA, where we've had a major focus on implementation science throughout the month of November. That's included webinars. Obviously, this is the fourth one today. It's included promotion and really sharing a whole lot of training options, including some major conferences that are interstate at the moment, one being run in the next week through Sydney Health Partners, which is one of our translation centres that we partner really closely with. So we'd encourage anybody to take that opportunity. We've also circulated lots of videos and publications on the implementation science topic. This has given us a chance to bring together a community across South Australia. And I was just talking to our next presenter, Alison Kitson, who's one of our board members. Professor Alison Kitson represents Flinders University on our Health Translation SA board, and we were just acknowledging the great numbers of people that have been attending these sessions and the appetite for information in this space. Our board has also recognised really clearly that we need to actually improve the work that's done across South Australia in this space, acknowledging that the subtleties of implementation are the things that sometimes do us in. So really important that happens. So today we're welcoming Alison Kitson and Sarah Hunter from Flinders University, from the Caring Futures Insitute. They're going to be talking about how to use an implementation framework to improve patient care. And also Saravana Kumar from University of South Australia, who will be talking about using implementation science and health service research. All the other four webinars are going to be available on the Health Translation SA website. And I strongly encourage you to review them if you haven't seen them, but also use them as teaching aids. There's been some fabulous case studies and things that I think are just so valuable to be hearing what's happening right here in South Australia. We've got some good stories. We don't share them and showcase them enough. So I strongly encourage you, but you'll hear more about that. So just briefly on Health Translation SA, as I mentioned, we're a partnership organisation. We're an NHMRC accredited translation centre. We have 11 active partners who are really committed to making this work across South Australia. Our little motto is Research, Action, Impact. We orient around impact, but as we know as a community that it's hard to get impact, and the understanding the subtleties of how you transfer knowledge and how you actually implement things is really important in the action phase if you are going to translate things to sustainable impact. The purpose of Health Translation SA is to accelerate research findings into healthcare practice and policy, as well as increase whole of system research translation capacity to improve the health of South Australians. We also work with the other translation centres across Australia to make sure that we can scale things when and where relevant and appropriate. The way we work is we work with all our partners and stakeholders as an independent catalyst and broker to really mobilise collaborations. And that's why this initiative is just so valuable to have people talking across and not just up and down, really talking with each other and working together. So with that, I think that's my last slide. Yes, indeed, it is. So I'd really like to hand over now to Professor Alison Kitson, as I mentioned, I'm a Flinders University board member, who's going to introduce the next session. And launch off in their topic, which is From the Frontline, how to use implementation frameworks to improve patient care. Over to you. Thank you.
Thank you so much, Wendy, and welcome. It's lovely for myself and Sarah to be here and to be invited to be part of this fourth and final webinar. Next slide, please, Sarah. So as Wendy has identified, we would also like to acknowledge the traditional owners of the land upon which we meet, the Garn people, and pay our respects to elders past, present, and emerging. Now, the outline that Sarah is, I've got her doing all the heavy lifting, isn't that right, Sarah? It's one of the benefits of having a research team. But tell us a bit about yourself. How did you get involved in this crazy world of implementation science?
No, of course, thanks, Alison. So, yeah, I've had a pretty, I think a very privileged journey where I finished my PhD at the end of 2017. So my background is in psychology, and I found myself having a PhD that was really heavily theoretical, very academic, and very much within the confines of an academic institution. And I found that quite frustrating because I was really passionate about what I did, but felt that I wasn't doing anything and I didn't know how to get my research out into the real world. And I was really fortunate toward the end of my PhD to meet Alison and to work with her in a casual capacity. And then she really introduced me to this world of implementation science and knowledge translation. And it really, I think, opened my world up a lot around, you know, doing research and having that impact is super crucial, and I think makes what we do more meaningful. And I think ever since, I've only been involved really in projects that are partnered with external organizations, with clinicians, consumers, and all sorts. And yes, I think it's a crazy world. It makes research a lot harder. It was definitely simpler when you stick within the confines of universities, but I can see how it's had so much more impact and meaning. So happy to do it.
Yeah, so as Sarah said, we probably will have a mix of people listening in today who will be clinicians, who will be researchers, who will be academics, and those who will have a mix, our feet in all of those camps. What I'm going to just outline very briefly is some of the work of 3 projects that Sarah's going to be talking about. Now, if you're a clinician, then you know that from July of this year, the Australian government has introduced a mandate that if there are certain readmissions that come into your acute hospital system, you won't be paid for caring for those people. So, for example, constipation or a non-ventilator hospital-acquired pneumonia are 2 areas where if someone rocks up who is a readmission, the hospital will have to provide that care for free. Equally, with delirium, we're going to have those sorts of challenges. Now, I'm starting here because we know that there are certain really practical things that you can do. Evidence-based interventions, like for delirium, if you encourage older people to eat properly, to keep mobilized and to engage, we know that reduces delirium. Equally, if you're able to wash people's teeth and do that routinely, research shows that reduces the incidence of non-ventilator hospital-acquired pneumonia. So those things that I've just talked about are what we call fundamentals of care. Next slide. And those fundamentals of care are the sort of things that nurses, allied health professionals, doctors, the whole multidisciplinary team need to sort of wake up and think about, because if we are going to solve some of the problems I've just articulated, then we need to know how we form the right sort of relationship with our patients, their families, how we integrate care around the physical, psychosocial, and relational, and how we do that within our fast-changing contexts. So I want you to be thinking about the complexity around some of the basic routine things we do in our complex health systems. Think about then how you would introduce an evidence-based intervention using implementation strategies a model, and in this sense, the IPARIS model. Think about the number of stakeholders that you need to be constantly engaging with, talking to, and think about how you can evaluate and tell that story that will then excite and energize clinicians to want to do more. So Sarah's going to rattle you through some of these frontline real life experiences that we've been having close up and personal in a couple of health systems not too far from you.
Thank you. There's a really nice introduction around Alison just talking about the complexities of fundamentals of care. So as you can see on this slide, this relates to oral health care and all the different factors that are involved in needing to actually provide high quality oral care. So this is based on a review that one of our honours students did. And I think it's a really nice visual depiction of all the various things that are involved in what is a seemingly simple thing, often something people think will just happen in hospital, that patients do it themselves, or that it's already being provided. But what we can see, there's a lot of factors at play. And this is when implementation science becomes really helpful, because it really helps you navigate what these different factors are, how we might use these to help us, how we can work through these things systematically, but also helps us to have at our front mind, like, what are our barriers going to be? What are all the different things that we take for granted that we're not actually appreciating when we go about implementing an evidence-based change or an evidence-based improvement? So what's really important for us, especially when it comes to looking at fundamentals of care, like I said, and like Alison said, these are the things people often take for granted, assume are already happening, and therefore people don't actually stop and think about what the problem is in their setting. So regardless of what implementation framework you're going to use, or regardless of what strategy you might go about, it's really important before you begin to think through what actually the problem is that you're going to overcome. It's really simple to just say, well, we want to get this new thing into practice. And that's definitely something that researchers, we do that because we know what our evidence is. We're very motivated by our innovations. We're really, really good at seeing how something can improve something. But when you think about the clinical setting, it's really trying to unpack what is the problem for them, and recognizing that different hospitals, different wards might have a different version of the problem. So it's easy to say the problem might be, well, they're not doing good oral health care. But that's not really the problem. The problem could be, is it that staff don't know how to provide the oral health care to those patients? Is it that this particular ward has a complex patient profile? Is it that patients don't actually do oral health care in their normal everyday life prior to hospital? These are the types of things we need to understand before we can actually go about coming up with an implementation strategy, because our strategy needs to factor these individual specific problems in. And the next thing is really trying to understand what exactly the evidence-based change is. Again, saying improving oral health care, it's really broad, it's really high level, and it might not actually be feasible then on the ground in that clinical setting. Is it that we're actually just trying to get patients to brush their teeth? Is it that we're actually just trying to get patients to clean their dentures? Being really specific around what that evidence-based improvement is going to be. And the next thing is where you're actually going to do this. Is it in one site? Is it with a certain number of patients? Is it hospital-wide? And again, you can start to see how these things haven't even factored in a framework yet. We're just really trying to be really clear on what our problem, our people, our context, and everything is before we can figure out what framework might suit us. And then going through the rest of that list there is who's being affected. Is this a staff change, patient change? Is it a team-based change, policy change? And again, coming then into the how are we going to go about doing this? And going through these questions in a systematic way and really thinking about them properly is going to help you figure out then the next thing, which is what framework is going to suit what you're trying to do. So the list we've got here is just a really small number of frameworks that we identified, that a group of us tried to think, how can we apply a framework, which framework is going to suit us? And these were the top 10 most used frameworks, but there are so many out there and it can be really overwhelming. And I think the important thing is going through those questions I just went through to think about what framework is going to suit your needs. Some are about culture change, some are about behavior change, some are just evaluation frameworks. Some help you plan, whereas some help you do. And I think once you understand what you're trying to achieve, it becomes a lot easier to figure out what framework is going to suit your needs. So the next thing coming back to is that problem. And understanding, have you actually measured what that problem is locally? Is there consensus around what that problem is for everyone? And then is it actually a priority problem? Again, I think as researchers, we're really good at thinking about what we think a problem is, but we know in clinical settings, there's so many things happening and this just might not be on the agenda. And from an implementation perspective, if it's not a priority problem, then you're never really going to have that change or impact if the local site is distracted by more important things going on for them. And then also making sure there's a shared understanding of what that problem is, or if you've got those different perspectives happening. So what this actually looks like, so for us, and we do this across a lot of our different projects, is really diving deep into a pre-implementation stage. So we have often used the IPARIS framework, and the joy of this framework is it really does help you unpack what that pre-implementation stage is and how to spend some time in that stage. And for us, we really focus on doing, patient interviews, so talking with patients around what, their experience is, what their view of the problem and evidence is. Doing a similar thing with staff, so making sure we talk to the different multidisciplinary staff to get their perspectives, to also conduct some context assessments to get an understanding of, what the resources, the leadership, and what's happening in that particular site, but then also doing some site observations or some audits to get a sense of what that local practice is. And on the right-hand side, we can see that, we do this so we can get an understanding of whether people see a need for a change. Are they happy with how things are, or do they agree something needs to happen? Do they have the appropriate skills and knowledge to do what we actually want to do? And does this change fit within their, the culture, the values, and the priorities of the site? And the reason why we do this and what we're starting to move toward is trying to work in partnership with our consumers and stakeholders. So we're very passionate about not going in and telling a site what they need to be done, and not going in that we have the idea of how things should be changed, but really taking stock of what their perspectives are and appreciating and respecting that their perspectives matter, and they can help us design an implementation approach, from their experience and understandings. So for us, it's really important to design our implementation plans in partnership with stakeholders. So what are their priorities? What is going to work for them in their context? And from my perspective, this really is key to successful implementation, because sometimes it actually is as simple as asking them. We spend a lot of time trying to figure out what we think might work, what those key mechanisms will be. And often the people in the site actually have the answers to those questions. They're there every day. They know what's the nuances of what their work site's like. And so if we actually involve them in the project from the very beginning, we can actually set ourselves up for a lot more success. As I mentioned before, there was a bunch of frameworks that have all different focuses. On the slide now, here are a few that involve stakeholders in implementation. And these are the ones that we find ourselves using a lot more frequently, because we do have that ethos of involving stakeholders. As a way of example, and Alison mentioned this project in her introduction, so we implemented a program called Eat, Walk, Engage. And I know, Jo, you're on the line here. She is involved in this project. So we wanted to implement this in one general medical ward at Flinders Medical Centre. So Eat, Walk, Engage is a program that's all about trying to prevent delirium in older patients, and it is a fundamentals of care intervention. It's involved around implementing a package of small activities tailored to patient needs and factors in local resources, and it's all around improving nutrition, hydration, and engagement. So we use the IPARIS framework, and that really focused on using facilitation as our approach. And the purpose of the facilitation was to ensure that those activities were tailored to the patient needs and the local resources. We also used an allied health assistant to help us enact some of these strategies. On the right-hand side, we've got a timeline of all the various activities that we did implement, and we did quite a few, and this was over an 18-month timeframe. As a way of example, through talking with our staff and our patients, one of the cognitive engagement activities was music therapy, and we did this weekly on the ward. This was something that the patients found really engaging and beneficial and really improved their time on the ward. Oh, it's jumping automatically, sorry. On the left-hand side, you can see that along with the staff, we came up with a pet board so staff could bring in photos of their pet. This was multifaceted in that it provided cognitive engagement for patients, but also provided them with a walking destination. So it improved both their mobility and cognitive engagement. As well, we did art therapy weekly as well. So the benefit of Flinders Medical Centre in South Australia is that we do have the arts and health embedded in the health system. And again, having the facilitators on this project was really beneficial because they could link in with existing resources. So rather than us as an external team coming in and coming up with a new strategy, we had a facilitator, which was Jo, who's on the webinar today, working within the site and tailoring what we can offer in partnership with what already exists in the site. And this starts to speak to what can be sustainable, because it means that this can continue beyond the life of the project. Because we're linking in with existing services that the site already has, we're not actually introducing anything new. We're just reworking what's already there to suit the priorities of this project, which was around the nutrition, mobility, and engagement. Another example of a project we did, this was around oral healthcare, and this was out at Noarlunga Hospital. So this project was a really interesting one because we had, again, facilitators working with the local site to try and identify how we could improve oral healthcare on the ward. And what was really nice to see in this project and this photo here is that this site really took a lot of local ownership over this project. So we tried to work with them to identify what we thought they could do on the ward, but they really worked with their own staff to come up with strategies that worked for them. And what you can see here is this Whitaker Smiles. This was a launch that we conducted. So they actually took the project, renamed it and reinvigorated it. And now Whitaker Smiles is a bit of an ethos and a program that they've established in the hospital, which I think really shows that when you work in partnership, again, it's not us as a team leading an implementation project, but us capacity building and enabling a local site to come up with their own ways to improve what is a high priority for them. So really what we're trying to get at is, for us, knowledge translation and implementation is all about working with your stakeholders. It's all about making sure that our end users are aware of research and that they're using it in a way to inform and improve their own clinical work and clinical experience. The engagement with stakeholders can vary. So like I said, we have quite a comprehensive approach. We work in partnership, but it can really be as simple as, consulting, but engaging, but as far as, co-designing and co-producing and having more of that participatory action research, which aligns a lot more with what we do in our projects. And again, working with your stakeholders and end users means you have a very different ways you can focus on your implementation outcomes. You can start to measure things more around the acceptability and feasibility of your work and appropriateness, because you're getting their perspectives and involvement in it, but also bearing in mind you've got your other outcomes, including, adoption, fidelity, and things like the cost and effectiveness as well. And this also means as well, you've got your different evaluation of processes. So a lot of what we do is with that facilitation is the formative. So we actually do cycles of evaluation that feeds back into what we do. We like to take stock throughout the project to reflect on, what's working and why, and can we change what we're doing based on that evaluation feedback, as opposed to more of your summative evaluation, which really just reflects at the end of, what did we do and did it work? And then you've got your comprehensive process evaluations, which is really trying to figure out what that key mechanism of change was. And I think this one's really important for implementation, trying to figure out, we had our problem, we've got our solution, but what was that key factor that actually made that change happen? And this can be really important when you're trying to scale up or trial in a new site. So that is a rapid overview.
Yeah. And just to finish, before we have a few questions, really it's to reinforce what Wendy said about the ethos of the Health Translation Centre, because research, action and impact. And I think we have reflected that it's the research that is generated will not be ever seen as valuable if you don't have partnerships, and that's between academia, researchers, clinicians, stakeholders. It won't be useful if you don't engage these stakeholders in activities that help them reflect on their everyday practice, and also think about how they can improve what they do. And that improvement and reflection only comes with an understanding and engagement and dialogue. And that also reflects the wider idea of knowledge translation, which is a whole ecosystem of implementation, of understanding stakeholder engagement, of understanding evaluation, of knowing how to construct the products in ways that busy clinicians will understand, and indeed how we start to ask questions that will help close this cycle. So again, rapid romp through what was an 18-month study, but now we'll stop and respond to any questions that people have.
Great. Thank you so much. That was really interesting and great to have a cap. I haven't actually been engaged in that project for a little while, so it was nice to hear the story. So thank you. Look, I think that many common themes that have come out in the prior webinar series, not surprisingly, problem identification, consistency, thinking about frameworks and thinking about getting something that works for you to help everybody on the team, not just the researchers, but, also bringing those clinicians and everyone along on the journey. And I think that importance of having the problem really specified and the context validated from the site itself, and making sure that people are really involved. So thank you very much for that. I'd just like to open up for questions. People can either put it on the chat, or you can just turn your camera on or start speaking. I'll try and field any of those. My first question, unless I can see one, has anyone got one? I can't see anything on the chat line at the moment. So fabulous presentation, and I loved your slides. You've obviously got some great slides.
I was going, given that we've got Joe Nolan, who was one of our jobbing facilitators, I think I'm going to dump Joe into it and ask her to share what she has learned and what she would do differently from the experience working with us.
Oh, there's a loaded question, Alison.
In the hot seat, Joe, go for it.
Well, I'd like COVID to go away. How about that for a start? Because that certainly was a complicating factor. I think the main thing I learned from the project was the complexity of the ward environment and how important it is to really link in with all the people involved, because managers and executives and academics all might have ideas about how things should happen, but the key people who care for patients are the people at the bedside, that whole team at the bedside, and that includes the, I'll say the orderlies, the PSAs, and the, all the people who work in the ward, not just the doctors, not just the nurses, not just the physios, OTs, social workers, but the whole team of people who interact. And the value of the volunteer service, which was enormous, and the importance of the patients' families and visitors to their care. So it is hugely complex.
And I think, Joe, that's a really important observation, because, again, as academics, we're often taught to think in straight lines, like you've got a problem, you have an intervention, you collect the data, and then you tell people this is how to do it. Whereas we're now sort of understanding, complexity network theory, or microcosms, or ecosystems. Even our language is starting to change, and if we haven't mapped out all of the different people who are either going to help to improve or change a system, or will keep it the way it is, we as interventionists will not be able to be successful. And I think that is so important.
I think it really highlights to me the importance of research being close to practice or relevant to practice. And a key question, I think, for all of us in implementation science is, how do we match make between the university's understanding? There's a lot that universities and health services can learn from one another, and a lot that each can do to support one another. But I think there's still poles apart in many ways, different drivers.
Yeah, I completely agree, Joe. And I guess that's part of the challenge that we have as a collective. And I'm saying that to all the people in the audience, how do we do that together? Because that's actually the nub of the issue. How do we actually identify the health service concerns and then bring the expertise to the table, as opposed to the research community saying, this is what I want to do, and then we drag the health services there? How do we flip that paradigm and be really working with unmet needs and then bring the expertise? So I think that two-way thinking is really essential at the moment.
And certainly, and I know from the work that the recent review of SAMRI and the research capacity across South Australia has identified the need to invest in clinical academic careers, and that's for the whole interdisciplinary team. So I can see Camille online. The more we can have PhDs, scholarships for clinicians, the more we can have early career research fellowships that really embed that partnership between research teams and clinical excellence. The more we can set up academic chairs in nursing, midwifery, allied health, this is the way that we're going to shift the culture and get people getting excited about solving some of these wicked problems that we continue to have. Because why, it doesn't make sense that we still have problems making sure that vulnerable people get their teeth washed every day, or that they can get food, or that they can walk to the loo, or that they're socially stimulated. We are a first world country, and yet we accept this sort of inequity. Why do we put up with it?
Yeah, it's very interesting, isn't it? So at this point, and given that COVID is, probably wreaked havoc with the project and things, how do you feel, and I can understand your cycles of improvement cycles as you've been going along, would you be able to say things have stuck at this point? Is the outcome sustainable yet, or are you in the position where you're working towards that? I mean, this is the always question, isn't it? Can we actually get things to stick? So I guess it's just but given the timeline, I can imagine this is a tricky question. So I'll open it up to you all.
I think we really were on the path to success. I think COVID, as Jo mentioned, really threw a spanner in the works, because that just threw out everyone's priorities and had to reframe what was achievable and what people were capable of doing. And that also meant then that any progress we did make got halted, and then we had to resume. And so we feel like at the end of the project, we were probably at what was the midpoint. And if we had the capacity to continue, we probably would have seen quite sustainable change, because we saw change. I just don't think we had the time to embed it to the point of sustainability.
Yeah, I think it's important reflecting on the Queen. This is a program, Wendy, that was developed in Queensland, and the Queensland researchers have rolled it out to something like 20 hospitals. And what they tell me is that to be sustained, you need to continue the half-time allied health assistant funding and to continue 0.2 facilitation. Otherwise, it just degrades over time. So we finished the implementation in June and did some process indicators in July and August. And the key, there was quite a big shift in several of the key process indicators. But how that's sustained over time is, I'm not confident that it would be sustained in 5 years' time, for example, because of the pressures of the context.
Yeah, and again, we know from research that unless you normalize or routinize, this is Carl May's work, if you don't routinize a new innovation, then it just evaporates out of the system. So it goes back to what Jo said about being clear about the resource. And of course, in a resource constrained facility, you have to show where you're saving the resource to put it into these extra positions. And that's the work that Alison, Mudge and her colleagues in Queensland have done. But the other thing, and this again is something that we have to be very careful about, is that often in health systems, it's the tyranny of the project. You do a project, you get everybody excited, and then a manager will say, okay, so now you roll it out across the hospital without actually understanding that the process of facilitating that rollout is a sort of scientific endeavor in itself. So yes, you can use quality improvement. Yes, you can use routine measurement. Yes, you can use KPIs, but unless you have those process skills, that can be within informal leadership roles, but additional support, then the sustainability is not in the system.
So I think that's a super helpful conversation to have. We haven't really been able to have time to have much conversation in the webinar series around this sustainability question. So I'm really glad we've been able to get to that and to be able to think through the complexity of getting something sustained. I mean, we've all got, as you started off, Sarah, good ideas are plentiful, and even engaging with health services, we're getting better at, making sure that these are co-designed projects, but the investment that's required for ongoing sustainability, I think, is something that we need to continue to focus on and understand more. So with that, I'd like to really thank you both for your time and your effort, and Jo for being part of the presentation team in the end.
Thanks, Jo.
Great to have you here, and really good to hear that that's a number of real life projects which are happening in Southern Adelaide are really using this collaborative approach and the frameworks and the everythings that go with implementation science and knowledge translation. So thank you very much.
Thanks for having us.
Great. I'm now going to move on to Saravana, who's our second presenter. Saravana is at Uni of South Australia, and has got is a physio by trade and has got a terrific track record. So I'd like to, especially organising many implementation science events and conferences and things. So I'd love him to do a quick introduction of himself, because he probably can do it better than me, but really welcome. And it's really terrific to have be bouncing from Flinders University and working in the South to the work you're going to be presenting. So welcome, Saravana, and over to you.
Thank you very much, Wendy. I'll just quickly share my screen and then I'll make a start. All right. Thanks again, Wendy and Annalise, for the invitation to come and speak to you all this afternoon about implementation science and health services research. As Wendy said, I am based at University of South Australia here in the East Campus. I'm a physio by trade. But my interest is in health services research and using implementation science to make a difference in people's lives. Like Wendy and Alison and Sarah, I also would like to acknowledge the Ghana people as the traditional custodians of this particular land that we meet on today, and also all the traditional owners of the land wherever that you guys are joining us from. We pay respect to their elders, current, past, and emerging as well. So today, I want to just tell you a story in terms of the role of implementation science in health services research. And part of my presentation, I want to talk about the challenges in healthcare. I can see from the attendees, there is a combination of clinicians, academic staff, and also researchers. I want to talk to you guys about some of the roles of how health services research can address that. And then use a case study as a case study in an implementation science framework to tell you about how I went about addressing some of these things, and then finish off about talking about some of the reflections from here. I don't have a research team like Alison does, so it's only me who's going to be presenting. So one day I aspire to have my own Sarah in my team. I don't need to tell you all, the healthcare is quite a complex space. Often people think about healthcare as something that is, relatively easy to deliver, but it's not. It's hugely complex, challenging, and continues to evolve. Healthcare in Australia continues to grow in terms of consumption for a number of reasons. And this is basically like teaching you how to suck eggs, really. We have an aging population with multiple comorbidities, increasing pressure on our healthcare resources. The pie is not growing, but the slices are continuing to be sliced away. There are challenges in terms of public and private sector funding, and Alison reflected on about some of the new funding rules that are coming in, have already come in. We also talk about the increasing need for quality in healthcare. I tell the story to my students at HTSA that when I went through uni in the late 90s, when the Spice Girls were on top of the charts, the power rested with me as a clinician in terms of I am the holder of knowledge. So to a patient, it'll be like, I'll tell you what is best for you. Now we have completely gone the other way because we recognize that it cannot be a paternalistic care. It has to be a consumer-directed, goal-oriented care where a patient is an active participant in decision-making. We continue to face a number of health inequities and inequalities and concerns with equity. Again, Alison reflected, as a first world country, we still have some really basic fundamental care that is not being met. And that is for everyone. But then when you talk about people who are socially disadvantaged or First Nation people, it's even worse. And then we also see equity in terms of rural and remote areas where we have this huge divide, where we have an oversupply in urban areas and undersupply in rural and remote regions as well. it is in this context we got to think about that in terms of delivery of healthcare, the challenges that we encounter and how it's important that we deliver good quality healthcare. And some of you might know Enoch Powell, who was the Minister of Health in UK, an interesting chap, but he does talk about there's virtually no limit to the amount of healthcare a person is capable of absorbing. And we see this in healthcare expenditure in Australia. This is a relatively old slide, but actually it's a really nice visual presentation looking at how we are spending in terms of healthcare expenditure. And clearly, not surprisingly, we are spending more. But obviously, as I say, devil is in the details. So when you look at where we are spending more, we know there are people who are getting older. So we have an aging population. There are more of us. Australian population is getting, there are more Australian people. But when you look at the gray bar, that is volume per case. So that basically is that we are doing more to our patients. So we are actually providing more treatment and more interventions to our patients. And we all know not all interventions good outcomes. Therefore, we have really shifted from volume-based care to value-based care. And again, many of you would have heard about this, where volume-based care is where we are looking at the measure of cost and resources for the healthcare services that we provide, and the benefit that we get back in return as well by for the amount of money that we are spending. There are interesting questions about whose value in terms of we are looking at, but it's very clear that we are moving to a value-based healthcare. So in that context, when you think about quality in healthcare, and Sarah talked about this early on, in that we want to know what problem are we addressing. But it's really difficult when we think about healthcare quality to define it and to measure it. When you think about a manufactured product where healthcare quality can be readily assessed, service quality is a very abstract concept, I think, and it's very difficult to define and measure. To give you an example, when I was a much younger person with a lot more hair and had a disposable income, if you said to me, what makes a good suit, Saravana, I would say, it's the Armani brand or the Versace brand, and because I like the brand name, etc. Whereas now that I'm married and I have a mortgage, if you say to me, what's a good suit, Saravana, I'd say Target is a good suit for me because it still does the job for me. So it's a manufactured product. We can touch it, we can feel it, we can define it. In a service quality, it's actually much more harder to define. Having said that, when we talk about healthcare, the quality of healthcare has been considered since the 60s. And probably the founding father of healthcare quality, I talk about that one, is the definition. And the quality is the degree to which health services in individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Now, we know, based on what we've just talked about, that many of the healthcare interventions that we provide may not necessarily give us the best benefit, give us the best outcome from that. So it's important for us to consider that quality framework. As I said, quality, while it's difficult to define, has been talked about for many, many decades now. And probably the founding father of healthcare quality is Avedis Donaburian. And he talks about healthcare quality as three distinct concepts. So you divide the healthcare quality into three parts. Structure, so this is the environment, the location, the resources that we need to provide healthcare, the workforce, for example. And interestingly, Joe talks about how, in terms of implementation, you need to sustain that 0.6 or 0.5 allied health assistant. So that's a structural issue. Process is how we deliver care. So this is the act of delivering healthcare. And that relates to what do we actually do when we have our patients or our populations in front of us. And then the outcome, which is the end result of care, which is the final product that we get from our healthcare service delivery. But we can also look at it from another way, which is Ishikawa's model. Ishikawa's model comes from manufacturing. It comes from Japan, where they look at car manufacturing. And they talk about, in order for us to get a good car, an efficient car, a timely produced car, what are the factors that influences it? And so here we can kind of superimpose that model from a healthcare point of view. And in order for us to get an optimal health outcome, there may be a number of different factors that contribute to that. Now, again, this picks up on the point that Sarah and Alison made, where there are a number of different levers that we may need to consider and engage in order for us to get a good outcome at the end. That might be people, so it might be patients, that might be clinicians, it might be materials, what we use to provide healthcare, it might be the environment, the clinic, the ward in which that we are operating in, and again, Joe talked about it before. It might be the methods in which we are implementing and collecting data. So now we can see the fishbone model talks about how there are different factors, different constructs that influences a health outcome. And probably the last model I just want to quickly talk to you about, it comes from Institute of Medicine in 2000. This was based on a really seminal work that was done by IOM looking at quality healthcare in US, where they wrote two reports, one called "To Error is Human" and "The Quality Chasm," which identified systemic issues in terms of quality in healthcare in US. So they talk about healthcare quality as being 6 key dimensions or elements. Safety, which is a really straightforward, you would think, something that we are all familiar with, which is relates to the health we provide should cause no harm to our patients. Effectiveness, the intervention that we provide should result in sustainable and durable outcomes. Equity relates to irrespective of gender, age, ethnicity, socioeconomic factors, everyone should have equitable access to care. Patient-centeredness, that relates to patients being an active participant in decision making. Timeliness, the length of time someone waits to have access to healthcare. And efficiency, value for money. The reason I put this up is when you're thinking about addressing a problem in healthcare, this is a nice framework for you to think about, what am I trying to address? Is it a safety issue? Is it an effectiveness issue? Is it an equity issue? Or is it a timeliness issue? It gives us that nice framework for us to sit back and reflect and then start our process. So how can health services help to improve quality of healthcare? And for that, I just want to take us one step back and talk about what is health services research? What do we mean by health services research? And there are a number of different definitions, but I like this one in particular because it talks about health services research is a multidisciplinary field. And again, it picks up on Alison's point about how implementation also relies on multidisciplinary approach, and which can both be basic or applied, that examines access to and the use of cost, quality, delivery, organization, finances, and outcomes of healthcare that produce new knowledge about structure, processes, and effects of health services for individuals and populations. Not surprisingly, you can see they reflect back onto the quality healthcare framework from Donna Bridden, where they talk about structure, processes, and so on. We know bringing together the health services and implementation science together, we know that when we think about health services in practice, there are a number of evidence practice gaps. Richard Grohl in 2004 talks about nearly half of the patients do not receive recommended care. A quarter of the patients receive diagnostic tests or medications which are not evidence-based, unnecessary, and potentially harmful. As a physio, I know when we refer patients to the GPs for low back pain, one of the common diagnostic tests that they get is X-ray, and we know that the diagnostic value of X-ray for low back pain is minimal, absolutely minimal. And we also know that some actually report that 2/3 of organizations' efforts to implement change actually fail over time as well. So we know there are some challenges in health services when we bring implementation into practice. Why are these issues? Well, there are a number of barriers. And again, this goes back to, if you think about the Ishikawa model, or if you think about what Alison and Sarah was saying, there are a number of different factors that can potentially result in derailing the implementation. It might be the patient. So we talk about patient expectations and patient perspectives. It might be the actual evidence-based practice process itself. It might be the team environment in which you work in. It might be a care process, because we all know, even though we all work in one system, how interventions are delivered can be hugely variable. Management support, and I think Alison talked about this, the importance of having leadership to support interventions. Time, facilities, and cost can play a huge role, and the health system itself can be a barrier as well. So there are a number of different barriers which potentially affect this particular issue in terms of the evidence practice gaps, why we continue to see these evidence practice gaps. So how can implementation science help? And Sarah had a beautiful slide where she summarized a number of different frameworks, including IFARS that Alison and Jill had developed. We have now moved from theories and frameworks to even meta-theoretical, right, where they have summarized multiple theories together. And I know one of my colleagues, Liz Lynch, has written a paper about bringing together different theories as well. But when you unpack all of those, what are the key things that comes out when you look about implementing evidence into practice are some critical things. One, intervention characteristics. So thinking about where does this intervention come from? How does this intervention compare, the new intervention compare to an existing intervention? Can it be adaptable to different contexts? Because context drives, has a huge impact. What are the cost issues associated with it? Similarly, there are things to consider in terms of patient needs and resources. What about the peers who support them in the implementation? What about external policies and incentives, which also drive that behavior change? Then there are organizational factors that we need to consider, communication, culture of implementation, the climate in which we operate. And then from an individual clinician point of view, you have knowledge, skills, self-efficacy, a fear associated with implementation. So a number of different factors. And then finally, and this picks up on Sarah's and Joe's point, is about the process of implementing change relating to planning, engaging, executing, reflecting, and then ongoing evaluation as well. So I just want to finish up by giving you one example of a case study that I was part of, which kind of brought together the health services research and implementation science. And this related to an evidence practice gap that we saw in clinical practice, where children with developmental delay were referred to allied health clinicians for them to be treated for that particular issue. The challenge the allied clinicians faced was because the children were referred to them. One, they had a delay in timely identification, which then resulted in delay in early intervention. And with children with developmental delay, it's really important to identify them early and intervene early, because it can cascade pretty quickly. So what we did was, and that's a critical point, because they actually identified that as an issue. It wasn't a researcher who came to them and said, look, this is a problem. Second, we worked in partnership with allied health clinicians, parents and families, because as allied health clinicians, we can only do 1 hour of treatment, perhaps, for example. It's the parents who are actually with the child for a number of hours, families and researchers. So over time, over an 18-month a project which involved workshops, educational outreach visits, understanding what the barriers and enablers were, understanding what the clinicians wanted. We ended up with a streamlined intake and assessment process, which had a family-centered focus, not a researcher or a clinician-centered, but a family-centered approach, and which resulted in development of a tool called the iRewards instrument. It sounds like a Woolworths reward system, but I can assure you it wasn't. It was iRewards stands for something. So what we did was we ended up with a one-pager, and that was really important for clinicians. They wanted a one-pager, not something which was hard for them to use, so they could easily use. And iReward stands for, the acronym stands for different things. But the only thing I'll flag is the I is the intervention. So straight away, what became clear was that when you see the child, you need to intervene. You cannot wait for a long period of time. Some really simple evidence-informed strategies to do so. So anyway, so that's what it looked like. As a result, we continued on evaluating it. And what we found after an 18-month period was that we had reduced the initial response time from 68 to 29 days. And then the maximum waiting time, 551 days for one family, unbelievable. It reduced to 201 days. And then the caregiver concern was 56 pre, and then post was 88. So we managed to bring it down further in terms of family-centered practice. As a result, the clinician team were nominated and won an SA Health Award as well. And it's interesting, we finished off the last presentation about sustaining. And I'm glad to say that I caught up with the team only a couple of days ago, talking about another project coming on, and they said that this is now sustained and it's been embedded in practice for a number of years now. It's not only has it been sustained, but it's actually evolved. Clinicians have taken ownership and have actually modified it from iRewards to meet and greet. So when they meet a parent with a child with developmental delay, they use this framework and talk to them about how to go about addressing it. And now it continues to evolve because the state government has developed a new strategy called early learning strategy to roll out next year. So they're going to use the meet and greet to adapt it even further. So I often put this slide up to teach my students in undergraduate first years, and I talk about the work of John Snow, who looked at cholera epidemic in Soho district in London, and I talk about John Snow, and they often say, is that dude from Game of Thrones? And I say, no, it's another John Snow. But what he did was he identified that there was a Broad Street pump which was contaminated with bad water, and that's why people were having cholera. And the solution was not a health solution. All he did was he removed the pump or the handle for the pump, and the cholera epidemic went away. So I guess my messaging is that sometimes the solution doesn't have to be health centric. It can come from other areas as well. So the key messages for me is be solutions focused. What's a gold standard for research may not be gold standard from a clinical point of view. So we need to balance the trigger with a practical solution. We need to be creative and recognize that co-design and the answers may not necessarily come from us, like John Snow removing the handle of the Broad Street pump, which was an engineering solution. We need to be patient and build capacity for change, and it can take a long time. As you said, my iRewards, we started this in 2016, and now in 2021 it's still continuing on, and it's continuing to adapt, looking for shared wins and maximizing outcomes and outputs, and recognizing that we may not necessarily get a flood straight away, but raindrops do make a flood. So where do we go from here? I guess the one of the silver lining of we are all pivoting. So there is a word, I had to use that word. We are all pivoting, but the health system has become quite responsive to change. The example I can tell you is telehealth. It has massive increase in telehealth, but now that we are going back to face-to-face, it's also starting to fall down, and we should not let it fall down. Telehealth can have some great positive benefits. We are seeing the role of virtual care that many people are using. And I heard this morning coming into work on radio that SA Health is going to distribute things like iPads and so on for people to monitor COVID symptoms at home. Building on partnerships and sustaining partnerships, as others have said already. And I guess the final message is that we still don't know a lot about the black box of implementation science. How does it work? Where does it work? Why does it work? So we still need to continue doing some work in this space. So thank you once again, Wendy, for giving me the opportunity to share some insights. Thank you.
Fantastic. Thanks, Saravana. Look, that was fabulous and a great way to wrap up the series. I'm aware that we've actually just got to nearly 1 o'clock. So I would encourage you to put any questions in the chat, unless there's someone with a quick one right now, and I can flick it to Saravana. Or otherwise, I think we've only got a minute to go. So I think I'll get people to put it in the chat. And then we can actually flick them through to you, Saravana, and to Alison and Sarah. If there's any further questions, please don't hesitate. But thank you so much. That was a great way to wrap it all up. And I loved your iRewards story, and also that it is now embedded in practice. So that's really a great outcome. And interesting that they're now building it into projects moving forward. So things on the horizon as well as before. So look, a really nice story. And I agree with you, the uptake of both telemedicine and also virtual care in other forms is actually a great outcome from COVID, and that we do need to do a lot more work on how we do that so that it is as effective as it possibly can for both the clinicians and also the patients, their families and their carers. So it really works for everybody, and I think there's still a lot to learn. So the more we can build the body of knowledge around that stuff from the consumer and also the clinician perspective, the better. So really terrific. Okay, so with those words, I'd like to wrap up. I'd like to thank you all for attending. I'd like to pass on my thanks to Annalise, who's not so well today, but she is online and is still our facilitator for the day. But she's really been terrific in pulling this all together, including the great range of speakers who've been able to be part of the webinar series. We will have information and all the presentations available on our website in probably a couple of weeks. Any questions, you can come through to inquiries at healthtranslationsa.org.au. Please visit our website, receive our newsletters and get involved. We are planning to continue the focus on implementation science moving into 2022 because it's needed. We're hearing loud and clear that people want to know more, people want to work out how to apply it, and clearly we need to have something that actually reaches more specifically into health services so that we can share the knowledge more broadly, but it's going to have to be a collective approach. So with those words, I'd like to thank you all for attending. Thank Annalise and the efforts she's made to pull this all together. Of course, thank our speakers, of which there were quite a few, and they were really a diverse and interesting range of not only the frameworks and the sort of more academic perspective, but a lot of great case studies about how you do it and what you do and what works. And I'll leave you with my final thought that I remind myself of all the time in this job, is that context matters, and that we have to think carefully about how we do things for the people that we're working with, and that we need to listen and learn and make sure that their thoughts and aspirations and ideas are always taken into consideration. So thank you very much, everybody. I look forward to working with you on the next Spotlight series. It's a little bit of a waiting game to work out exactly what that Spotlight series will be on, but it will be kicking off 2022 and will be in the month of February. So look forward to working with you in the